COG webinar. How beautifully everything is arranged by Almighty. That as soon as child enters into this world, mother is ready to take care of it. Father may not be there, Dr. Sima, but mother is always there. So Sultan may not be there, but Salima will be there to protect the baby. With the blessings of so many mothers, three books written by us is recommended in Royal College as a reading material. The Atlas of Fetal Echocardiography and Technique of IVF Made Easy has gone for second edition. I am editor-in-chief of two journals, that is Indian Journal of Obstetrics and Gynecology and Open Access Journal in Gynecology, worked as a KOL in dydrogesterone. And recently I got opportunity to interview Professor Herman Tourne in Ashray, Copenhagen. So if anybody wants to listen that all interview and all my presentation, they can just log on to Manish 4269 YouTube channel. First I am talking about the female sexual dysfunction. We all know. Yesterday I had seen very good picture, Murder Mubarak. It is all about love and lust. Man and woman initiate to agree to sexual activity for many reasons, including sharing their sexual excitement, physical pleasure, and experiencing affection, love, romance, intimacy. However, women may more likely to devote emotionally and motivational, such as experience and encourage emotional intimacy, increase their sense of well-being, confirm their desirability, and to please or placate the partner. Especially in establishing relationship, women often have a little or no initial sense of sexual desire. That is almost common worldwide. But the actual sexual desire, that is the responsive desire, once stimulation triggers excitement and pleasure, that is a subjective arousal, and genital congestion, physical genital arousal. Desire of sexual satisfaction, which may or may not include one of the multiple orgasms, builds as sexual activity, intimacy of continuing physical and emotional, rewarding experience fulfills and reinforces the woman's original motivation. So, woman's sexual response cycle is strongly influenced by her mental health and quality of her relationship with the partner. Initial typical desire lessen with age, but this sentence I love most, Dr. Sima, that increases with a new partner at any age. I don't know why this sentence is very common in every sexual dysfunction presentation. So we all know that female sexual response, that is based on Master and Jones graph, that is stage of excitement, that is a stage of excitement, then plateau, then orgasm, then there is a refractory phase. This is usually a female sexual response cycle, and it is common everywhere. This is secondary Rosebery-Basson non-linear model. It is based on a simple cycle or female response cycle, that is emotional intimacy, then there is a sexual stimuli, then it goes for sexual arousal, then there is a desire, then there is emotional and physical satisfaction. This all will combine to get the very good sexual response, incorporate the need of intimacy, acknowledgement that desire can be responsive to someone or something else, or spontaneous and may come either before or after the arousal. If we see what are the different four phases of female sexual response. First phase is female excitement phase. Second phase is plateau phase. Third phase is orgasm phase, and fourth is resolution phase. If you see the uterus, we call it is an organ inside the abdomen. Once we are doing intercourse into the vagina, the clitoris grows, labia enlarges, there is bulging in the labia. With this proper intercourse, there is elevation and uterus is starting moving. And with this full orgasm, uterus may have got contraction in the uterus, and sometimes they feel very good feeling at the level of umbilicus. So uterus returns in normal position at the stage of final resolution. So female sexual dysfunction or FSD, there are typical things of disorder of arousal, that is known as interest of arousal dysfunction. There is a disorder of orgasm, that is female orgasm dysfunction, and pain disorders like a genitopelvic pain penetration dysfunction, vaginismus, and vestibulodynia. There is a typical biopsychosocial model. So if we see that any sexual activity has got relation with biology, personal affection, psychosocial model. So FDS is a complex interplay of biological, hormonal and psychological factors that can have a significant negative effect on female sexual health and quality of life. Particularly country like India, we have got so many social taboos, so many social myths, so many social restrictions particular religion and the community of people that also allow a arousal of FSD. FSD can be influenced by several dynamic factors like advancing age, social factors, psychosocial stress, and trauma. What is the contributor factors for FSD, female sexual disorder? Most common is decline in estrogen. So we all know that estrogen should be there to nourish the vagina, to have a lubrication in the vagina. We must have very good lactobacillus. We have got very good androgen. We must have very good androgen level. If she is in menopause, I will give definition of menopause like this. It is not man oppose. It is not moon at the pose. If you think there is no oppose and there is no pause in sexual life, that is menopause. There are typical medical conditions like hypertension, diabetes, psychiatric conditions such as depression and anxiety, some cultural norms and religious belief. Most important is past abuse and trauma. If there is child abuse or child POXO is there in woman's life, they are restricting her sexual activity in early marital life, and also she is not able to give her 100% to her husband when there is a trauma of past abuse. Sometimes she is taking some drug and that drug also induces FSD. What is first female sexual interest or arousal dysfunction? By definition, it is absence or decrease in sexual interest, desire, thought and fantasies, and absence of responsive desire. Male is there to arouse her, but there is responsive desire is absent. Maybe expressed as a lack of subjective excitement or lack of genital lubrications or swellings. Orgasm that is absent, markedly diminished in the intensity or markedly delayed in response to stimuli despite high level of subjective arousal. Male is trying a lot, but she is not able to respond to any of the subjective stimuli done by the partner. What we call it as a primary, when she had never attained orgasm. Emotional trauma or sexual abuse are the most prime cause of primary female organic disorder. Secondary, maybe because of local surgery, or she is on some hormones, or she is in menopause, or there is a history of trauma at the vaginal site, or history of some nerve injury, spinal injury, or there is multiple deliveries, there is difficulty, or there is injury to the musculature. So many traumas can also cause female orgasmic disorder. This word I like most. GPPPD. Genitopelvic pain penetration disorder. Don't write vaginismus, don't write dyspareunia, write GPPD. It also looks good, but it is vaginismus. It is a reflexive tightening around the vagina when vaginal entry is attempted or man wants to introduce the penis and complete despite woman express desire for penetration and no structural or other physical abnormality are present in the woman. So it is just pain penetration disorder. Female pelvic pain penetration disorder. Second is dyspareunia. So he is able to introduce the penis, but pain is during attempt or completed vaginal penetration or intercourse. This is provoked by vestibulodynia, that is PVD, provoked vestibulodynia, formerly called vulval vestibulitis. The most common type of superficial or introital dyspareunia. It is a chronic pain syndrome associated with altered immune function and sensitization of the nervous system. So many times this dyspareunia may be because of inside the endometriosis, some ovarian cyst like a hemorrhagic cyst or follicular cyst, or there is a fear of pain penetration disorder. So when anybody wants to introduce, there is a pain, and there is a more sensitive vulva will be there. So there may be a hypersensitive nervous system at the level of vestibule. So what is the etiology of female sexual dysfunction? It may be vasculogenic, it may be neurogenic, maybe because of hormone or endocrine disorder, musculogenic, and lastly the psychogenic disorder. What we mean by vasculogenic? There are so many risk factors are there in women's life. Women are not devoid of hypertension, hypercholesteremia. Now they are smoking, they are chewing tobaccos, they are taking liquor. So she may have got heart disease also. It is associated with erectile dysfunction in men and sexual dysfunction in women. Diminished vaginal and clitoral blood flow. That may be because of the atherosclerosis. You can see very small clitoris, even after stimulation, clitoris doesn't give any response. It may be because of the result in symptoms of vaginal dryness and dyspareunia. Alteration of circulating estrogen level. That is, maybe she is going in perimenopause or menopause, or in there is a lack of estrogen available in body, and that may cause atrophy of vagina and clitoric smooth muscles. Traumatic arterial dysfunction, particularly in she is suffering from pelvic fracture or blunt trauma, surgical disruption, chronic pressure. Suppose the person who is doing so much of bicycling, they have got chronic pressure over this clitoris, and that may cause chronic perineal pressure because of the bicycle riding. Neurogenic, the Ursi has already told about the patient is not suffering from any spinal cord injury, but neurogenic can be because of the diabetes mellitus. Chronic diabetes mellitus can have a peripheral vascular neuropathy, and that also causing sexual arousal disorder. Complete upper motor neuron disease or incomplete spinal cord section, that is capacity of psychological arousal and vaginal lubrication will not be there because of the incomplete spinal cord injury. There are deficiencies in the hormone and endocrine. We all know that woman is having very good hypothalamo, pituitary, ovarian, uterine axis. If this HPO axis is working very well, then she has got very good hormonal and endocrine function, and that is it should be there for any organic things to happen in body. If she want to take a good food, we must have a hypothalamic response, that stomach should be aroused to get our food. Likewise for sexual desire, there should be enough amount of estrogen should be there. If that estrogen is causing arousal, estrogen is also causing arousal of the clitoris as well as of the uterus. That hormonal endocrine disorder may be because of the medical or surgical castration. Suppose during her hysterectomy, somebody has removed both the ovaries, or she had taken so much of hormones, or she may be suffering from primary ovarian failure. High FSH should be there, it is there. So it is also causing hormonal disturbances. Chronic birth control pill use. Now we can see that people are using this contraceptive pills just like chewing gum. So it also causes hormonal and endocrine, because chronic suppression of anything will lead to improper hormone secretion from the hypothalamus. This may cause symptoms like decreased desire, vaginal dryness, lack of sexual arousal. Musculogenic may be because of levator ani muscles or perineal muscles. Particularly during episiotomy, we had injured, or if baby is big, if patient has got a big baby or obstructed labor, and we had done forceps or we had applied vacuum. Previously, we are doing mid cavity forceps also. They are causing levator ani muscle injury. Or there is during big episiotomy, there is perineal membrane injury like bulbocavernosus or ischiocavernosus muscle injury is there. They are all taking part in the female orgasm. So whenever we are delivering the baby, you also have to take care of her future sexual activity. Always try to give her the original vagina by giving very good episiotomy, and don't give this $1 million stitch insufficient. It should be like particularly normal vagina as she is bare pre-delivery, and this may lead to very good contractile activity and arousal and orgasm. Sometimes because of this musculogenic injury, there may be hypertonicity, they cause vaginismus and dyspareunia, or there is hypotonicity. Even after giving so much of stimulus, there is no vaginal contraction, that may give rise to vaginal hypoanesthesia, coital anorgasmia, urinary incontinence, and there are chances that because of big baby there may be sphincteric injury at the level of urethra, and she may be suffering from incontinence, and sometimes she can micturate during the time of intercourse or during the time of orgasm. Psychogenic, emotional and relational issues are there. She may not be of her proper self-esteem. If she is obese, if she is thin, if she has got deformity in the body, because everyone wants to have everything will be good in their body. Somebody has got good breast, so somebody has got good boobs. So everybody doesn't get the same thing. So that may cause her lose of self-esteem, and because of her this body image in their mind, the quality of relationship partner will be disturbed. Or she is taking serotonin reuptake inhibitors that also causes psychogenic disturbance in female sexual dysfunction. So we have to evaluate these clinical symptoms of female sexual response medically, psychologically, psychosexual assessment should be there. So there is, we have to take full history. When I say full history, means we have to follow the Bible. Give thou ears, listen them carefully. Just don't ask, listen them. They will give 90% of positive finding in their history. If we ask what is the definition of history, history is study of past in light of present to have good future. So patient has came to us for her disease resolve. Patient has came to us for cure of his problem or her problem. So we have to give good future. She has got something in past, she is narrating in present, so we have to delete that negative part from the history and we have to give her good quality life. Then comes physical examination. She has done very good physical examination of male and female both. Then if required, we have to go for hormone assessment like FSH, LH, free testosterone, SHBG and estradiol. Evaluation of sexual response by Doppler. Here we have got very good ultrasound Doppler machine. You have to see for vaginal pH, because nowadays in last X-ray we have got more and more concessions on vaginal microbiota. In India we are very rich in lactobacillus, because in India we used to take buttermilk in our food. Buttermilk is very good natural source of lactobacillus, and in Western India, or if you see any Shushruta Samhita, whenever there is vaginal infection, they try to say that use vaginal douche of buttermilk, because buttermilk is containing very good lactobacillus, so it will kill all this acidic environment and have a proper, very good vaginal positive microflora. And nowadays it is established that for good pregnancy, there should be very good vaginal microbiota in the vagina. They had tried that good vaginal microbiota, they are implanting or they are taking the soap from good vagina and putting into the vagina which is deficient in lactobacillus and all positive growth bacteria. They found that after replacing the vaginal microbiota from healthy individual to the non-healthy individual, the pregnancy rate increases. So here also in orgasm or in female sexual dysfunction, we have to see for vaginal pH also. If vaginal pH is too much acidic, then she doesn't have that desire of penetration. If anybody wants to penetrate, there will be severe pain or burning sensation even on the male part. And we have to see for vaginal compliance and elasticity. It should be properly elastic should be there, so they can enjoy the sex. Genital suspension by vibratory perception threshold. It is also it's a test by vibroacoustic stimulation. We can have a vibrator available, and with that vibrator we can have a very good vaginal sensation test. So diagnosis of sexual function and its causes is based on history, physical examination, ideally history taken from both partners. In our center, it is our custom that we give a separate sheet of paper like this to both the partners, and we tell them, right, what are your complaints? And you able to see that there are different complaints of both. Then we interview them separately, then together, and begins the conversation. So many times we can see that they are fighting with each other, and ultimately that fighting resolves because they are fighting in front of the doctors, fighting that with the verbal fight. And from that verbal fight, we have to take all negatives from their sexual experience. We have to identify the what are the tests should be done, and how we have to take care of this couple to have a devoid of female sexual disorder part. Physical examination is most important part, particularly cases of dyspareunia. With simple pervaginal examination, we are able to find that she is suffering from endometriosis, that is deep-seated endometriosis, third degree endometriosis, or endometriosis with rectal nodule. If we find there is some rectal nodule, is that we are doing BB with one finger in vagina and one finger in rectum, and in between we are able to palpate it, and when we are in doubt, we can go for MRI. The technique may differ slightly from that used in routine gynecological examination. We have to start for dyspareunia cases. We have to start with one finger examination. And so many times I used to tell the female that this is my one finger. Just put in your vagina. You put by yourself, and if you feel pain, we don't proceed. So let her confidence build that if she puts something in vagina, there is no injury. Then afterwards we are putting two fingers. Then we are using with condom. This don't mean that I used to put my finger without condoms or without gloves. It is always glosed one, so we have to prevent ourselves also. Explaining what will occur during examination help the woman to relax, and sometimes we have to give them a mirror in front of that. Let's say there is nothing is going to happen. You can see that everything is fine, and this dyspareunia may be because of psychological cause. So psychosocial, psychosexual assessment, it addresses emotional and relation issue. Brief index of sexual function, that is BISFW, and inventory of female sexual function, that is IFSC. These all things are available on net, and you have to take one by one to get the inventory of female sexual function. Distress is the keyword. Why that came to us? Because of distress. So a diagnosis of distress is a symptom. Some women may not be distressed or bothered by deceased or absent sexual desire, interest, arousal and orgasm. Sometimes it is the distress of the partner. It made her to come to you that now she has got no interest. Doctor, please help us. So their issue is not to be diagnosed as a dysfunction, and we have to talk with them, we have to counsel them, and we have to give them good relief of their symptoms. So female sexual disorder may be a secondary category as a lifelong or acquired, situational, specific or generalized. That may be based on mild, moderate or severe based on the degree of distress that is causes to woman. Remember, almost all women's sexual function have features of one or more disorder. Male sexual dysfunction could be also cause of female sexual dysfunction. It is not that always the female is the culprit. There might be a male is suffering from sexual dysfunction, and that might be the cause of her dysfunction. So what we give her around the treatment, we have to explain for the female sexual response to the couple. We have to correct all the contributing factors. Substitution of other antidepressant like SSRI or addition of buprenorphine, and we have to give sometimes psychological therapies to that couple. Generalized treatment varies by disorder and cause. Often more than one treatment is required because of the disorder may overlap. Sympathetic understanding of the patient and careful evaluation themselves may be a therapeutic. Contributing factors are corrected if possible. Mood disorders are treated. Sometimes you have to give them the proper environment. You have to give that make a mood. It is not that sex just like you are moving on a road and you are doing sex. It should be enjoyed. So you have to create the moment. You have to acquire the moment. You have to make the good ambience. So we have to explain what is involved in the female sexual response may also help. It is not like that just we are going for sex. Just give her proper foreplay. Give her proper ambience. There should be very good soothing environment. There should be good arousal or good aroma should be there in the environment. That will also help in the treatment. What are the current treatment options for female sexual dysfunction? Currently, we have got philbinsterin. We are using testosterone. We are using low dose estrogen therapy, and recently we have got very good estrogen gels are also available. Osmeverifan, vaginal moisturizers and lubricant. There are so many drugs. Now you see, these are list of drugs which is available in pipeline since 2015, and they all are there for female sexual dysfunction. They are alprostendil, apomorphine, bremelanotide, bupropion, that is muproprin, that is bupropion, diphenyl dihydroepiandrosterone, that is available in India, and PDE5 inhibitors, that is phosphodiesterase type 5 inhibitors are there. So there are things, because why there are need of so many different drugs for female sexual dysfunction? Because they are there. So they are there, then we are able to give them the treatment. Now talk about the FSD and FDA. Whenever we want to give any drug, we have to take care of federal drug. So most drugs are off-label indicated in female sexual dysfunction. Use of hormone therapies for FSD is most prominent documented, particularly estrogen therapy in post-menopausal women. There are lots of controlled study available for hormonal therapies for FSD in perimenopausal women are virtually there. SSRI have been reported to negative impact on desire, arousal, and orgasm. They are there, but they have got negative effect. Psychological therapies, they are the mainstay of treatment. They are the mainstay of treatment. Give them proper counseling. Cognitive behavior therapies target the negative and often catastrophic self-view result from FSD or illness contributing to it. Just talk them, give the ear, listen them carefully, and one by one remove all negatives. Mindfulness practice. Nowadays in all IOS there is mindfulness that also helps free women for their distraction and that interfere with the attention to sexual sensation. So you have to take very good mindfulness. There are visuals are there. They will make your mind fullness. Mindfulness lesion, sexual dysfunctions, both in healthy women and those who have got medical issues. In Eastern practice, with roots of Buddhist in medication, mindfulness is the Buddhist medication. And recent movie Love, Hate and Pray by Julia Roberts, she is doing all this Buddhist meditation and she find very good this type of meditation available in India. So India is rich in mindfulness. It focuses on non-judgmental awareness of present moment. We can use vaginal moisturizer and lubricant, and worldwide this is available for the treatment of mild dyspareunia. Non-hormonal OTCs agent can be effective. Vaginal agents are formulated as moisturizers and lubricant. Moisturizers are applied daily in form of gel or liquid, or sometimes they replenish the vaginal moisture. One popular moisturizer is formulated to adhere per vaginal lining for 3 to 5 days. They are claiming that it is there for 3 to 5 days. It will adhere in the vaginal stratified squamous epithelium, non-keratinized. Moisturizer are more effective if used are on regular basis. Lubricant are as needed, with the water-based product being the most popular, but lubricants can contain menthol marked as a warning agent, and menthol has got very cool effect, but that should not be used particularly when you want to go for sex with copulation. If there is sex for enjoyment, then you can use this with menthol. So this branch of female sexual medicine is basically a bridging branch. This is not a bridging course by this Ayurvedic doctors and homeopathy doctors and medical doctors. This is between our branch. Patient may come to us, patient can go in medicine, patient can go in urology doctor, patient can go for psychiatry, and my wife is always doing dermatology practice. So many patients are going to her that now we have got problem and she is referring for the right cases with the help of treatment. So men need his difficulty because they are necessary to enjoy the success. Just time stop sharing my screen and let's see if I have got time. I will go for next session of male dysfunction. Sima madam.